Hi, my name's Peter Acker. I'm a clinical instructor in the Department of Surgery and Emergency Medicine at Stanford University. And today we're going to be talking about anaphylaxis. This is part 3 of a case of a 33-year-old gentleman who presented to us with some lip swelling and abdominal pain. We've noted him to have a number of vital sign abnormalities and some concerning findings on his initial assessment and focused exam. After putting all the pieces together, we've found that he does in fact meet criteria for anaphylaxis. He not only has an exposure and hypotension, but he also has greater than 2 organ systems involved. So this gentleman most certainly has anaphylaxis. So what is anaphylaxis? Basically, it's a state in which an allergenic antigen is bound by the patient's own immune system. It's brought into the basophils and mast cells and activates them. This causes a massive release of biochemical mediators, things like histamine, tryptase, nitric oxide, and a few others. These then affect or have the ability to affect almost any organ system in the body. We see often cardiac dysfunction as part of the picture, vasodilation, and increased capillary permeability. The manifestations of this, combining the cardiac dysfunction and the vasodilatation, can cause cardiovascular collapse, and the increased capillary permeability leads to edema. We see this in the airway, potentially like lip swelling or tongue swelling, as we saw in our patient, or in many other organ systems, like the raised rash that we saw in our patient, or the abdominal pain is often GI mucosal swelling. So it can affect almost any organ system. So we have evaluated this patient. We've performed a history, a focus physical. We've determined items on our differential and sifted through to the point where we feel like this is anaphylaxis, and we've provided some therapeutic interventions. So now it's time for further treatment and disposition. So discussing the interventions that we must provide for patients with anaphylaxis, epinephrine truly is the first line of therapy. It's an alpha and beta agonist, and it counters the effects of a lot of the biochemical mediators that cause the symptoms patients experience. The initial treatment, as we mentioned before, is 0.3 to 0.5 milligrams intramuscularly every 5 to 15 minutes. Intramuscularly is preferred because the uptake of the medication is improved versus subcutaneous injections. And the lateral thigh is the preferred site of injection because the blood flow there is higher and allows for more rapid uptake. Intravenous fluids are a very essential component of the treatment for these patients. Up to 35% of a patient's intravascular volume can move into the extravascular space in the first few minutes of onset. So it's important that we replenish the intravascular volume. We usually start with 1 or 2 liters, but patients may need much more. There are also adjunctive treatments. Oftentimes we use H1 blockers, things like diphenhydramine or phenyramine, and these help relieve some of the itch and hives, but unfortunately they don't benefit airway edema or the hypotension. We also use H2 blockers, things like ranitidine or famotidine, and they act very similarly to the H1 blockers, helping with some of the rash and itch, but unfortunately also don't help with any of the edema or hypotension. Bronchodilators are another component of our adjunctive therapies. For patients with wheeze that's not responsive to epinephrine, this can be helpful to add on, but unfortunately this also doesn't relieve the airway edema, but can potentially help some of the wheezing symptoms. Lastly, glucocorticoids are a medication that's commonly given to patients with allergic reactions and anaphylaxis. The hope is that these potent anti-inflammatories will decrease some of the inflammation and edema that's associated with these conditions. There's also some hope that it will blunt the biphasic reaction that we see in up to about 1/4 of adult patients with anaphylaxis and about 11% of kids. Unfortunately, they are a little bit slow to act, and so definitely not going to help the acute symptoms that patients often present with. However, as a caution, Don't rely on the adjuncts. As we just discussed, none of these are going to improve the edema or the hypotension that potentially could kill these patients. Epinephrine and fluids are truly the first-line therapy. So now returning to our case, we see our patient has become a little bit sicker. His blood pressure is now 65/35. The heart rate is increased to 135, and it looks like things have progressed. So is this patient sick? We already determined he is, but now he's much sicker. So a caution, whenever a patient's status changes, for instance, this patient with vital sign changes, it's important to reassess them and start with the ABCs. These then prompt reassessment and intervention for the most acutely life-threatening illnesses. So when we reevaluate this patient, we see that he's less alert, he's pale appearing, and he's lying on the bed. When we assess his airway, we hear some upper airway stridor. His voice is somewhat muffled and his tongue is swollen. When we assess his breathing, he's breathing rapidly. We note retractions, and he's in severe respiratory distress. Assessing the circulation, we see his capillary refill is decreased at 4 seconds. His extremities are cool, and he has weak distal pulses. So there's a number of very concerning findings on his general appearance, level of consciousness, and the ABC exam. So now it's time to think. He has poor distal perfusion, he has obvious respiratory distress, he has hypotension and tachycardia in the setting of anaphylaxis. So he has what we would describe as distributive shock and a pending respiratory arrest. He's very sick and needs immediate interventions. So we've already positioned this patient. We've given him oxygen. We put him on a cardiac monitor and placed an IV. We've given him fluids and epinephrine intramuscularly, but obviously he needs further intervention as he's declining rapidly. So we will now open his airway and we'll provide further fluid and IV medications, which we'll discuss. A caution, early airway management is critical for patients with airway edema. The longer the airway edema progresses, the more difficult airway management will become. So it's really essential to manage the airway very early. So this patient clearly needs intubation, and there's a couple of items to consider when planning an intubation for a patient with airway edema. These patients are by definition going to be difficult intubations, and so we want to approach them cautiously. We may want to consider an awake intubation, one in which we preserve the patient's respiratory drive to allow them to continue oxygenating while we attempt to control the airway. We may also want to consider downsizing the endotracheal tube, as with the airway edema that we're going to encounter, a smaller tube will pass more easily. Any patient with airway edema may end up needing a surgical airway, so it's essential to have the surgical airway equipment readily available at the bedside. And it's also important to call for backup. These are very difficult airways, and we may need help from our colleagues from anesthesia or otolaryngology to help with either the traditional airway management or surgical airway management. We also want to consider a few more therapeutic interventions. We'll continue with additional IV normal saline. He initially got 1 to 2 liter boluses. We want to provide rapidly further fluid, and some of these patients may require up to 7 or 8 liters. So it's okay to give them a large amount of fluid if their blood pressure needs it. Additional epinephrine is also key. As we discussed, you can give the 0.3 to 0.5 milligrams every 5 to 15 minutes. So we'd like to continue that, and this patient definitely requires further epinephrine. However, a caution is that for patients with shock refractory to intramuscular epinephrine, they should be started on intravenous epinephrine infusions. So for this patient, he definitely would benefit from intravenous epinephrine. The dose is usually 2 to 10 micrograms per minute, and we prefer an infusion to a bolus, as with boluses, often dose calculations can be made and some of the ill effects of epinephrine overdose are seen. So this patient definitely would need intravenous epinephrine. So in summary, Epinephrine is the only critical medication. Adjuncts are simply adjuncts. Epinephrine is the first-line treatment, and intramuscular is the initial treatment. However, if they fail intramuscular therapy, we should promptly move on to IV epinephrine for refractory shock. It's also key to perform airway management early in any patient with airway edema. And we also must prepare for a difficult airway, as patients with airway edema can present a lot of challenges when intubating.